Good morning. It's a pleasure to be here today with you this morning. I was going to start by talking about reliability, and of course we always talk about aviation. Well, they lost my bag last night. It did arrive at 4 a.m. this morning, so perhaps it wasn't so bad after all. Today I want to talk about high reliability organizations, but I don't want us to talk about the typical mantras of it, because I believe that there's a huge opportunity to really go a lot deeper about what this actually means for you. We have a very distinguished panel this morning. The goal today is to be very practical. What will you do differently tomorrow? If you don't come away with things that you can do in your organizations tomorrow, then we as a panel have failed, I think. But of course, this is about the interactivity with you all. So I want to start, before I actually introduce the panel, I want to actually hear from for you all. So just by show of hands, how many of you in the room are risk managers? How many of you are practicing or otherwise physicians? How many are C-suite executives? Okay. Others that I've missed? Consultant? Pharmacist? As we know, high reliability organizational theory is premised on the fact that senior management believes in the vision of introducing these concepts. And the tension between what management wants and what actually gets executed on the ground is, of course, part of what we'll be discussing today. So our two panelists have had a lot of experience with high reliability. First is Craig Clapper, and I've been a great fan of Craig. I've only first time met Craig this morning, but I've been a fan for many years. I particularly came across Craig's work around Cincinnati children, Craig. There's actually a slide that you all prepared that's circulating across the web, a lovely graphic on what it needs to go from 0 to 10 to the -8. And Craig's a systems engineer, part of HPI, which has been around for 7 or 8 years. We discussed recently aligning with press gaining, a very unusual move, which I think is perhaps part of a broader perspective of how more focus on execution, implementation, and less about diagnostics, which is what Press Ganey is well known for, and I think that's a very interesting relationship which Craig will speak to. Coleen Smith, who's a nurse and heads the Joint Commission's Center for Transformation. Of course, the Joint Commission for many years now has been focusing on high reliability principles with their different model, applied model, which Coleen will talk to. And again, trying to bring the regulator focus into how do we actually execute improvement, not just compliance. The third person who couldn't make it this morning, you have her name on the back of the schedule, Maureen from DNV, unfortunately could not join us. But I also want to say in this juncture that we plan for this not to be just this morning's session, but we're going to add quite a few materials onto the website, which will include both a summary of the discussion today as well as some other reference materials as a way to try to encourage a further dialogue and discussion amongst this community. So I'm going to start, first of all, by asking you to write something down. I want you to write down and answer this question. Do you think your organization, to your best of your knowledge, adopts or deploys high reliability organizational principles? And I realize that I'm asking you to do something as if you know all about HROs, and I imagine you know quite a bit about them already. So could you humor me and for about 1 minute write down and be particular, what elements of HRO theory does your organization deploy right now? Not just in rhetoric, but in action. That directly connects to operational improvement, to safety, to harm reduction, to engagement, to all those things. One of the most powerful elements of improvement science, which comes from the Japanese Kaizen, is the humility and reflection that's required for improvement. And I just came from Japan, where I periodically do some work, and I'm constantly struck by how the best organizations in Japan in manufacturing are the most humblest in what they say they can and do. And as Craig was saying, sometimes they compete in being humbler. But it's an interesting concept, and the analogy here is very clear. high reliability organizations require a humility to understand how much further they need to go to implement and execute in a very streamlined way. Again, the goal is to really bring out some of those experiences and share across the different systems that are trying to introduce it. So we'll start with Coleen. Some opening remarks, please.
My job is with the part of the Joint Commission that isn't associated with accreditation. Not a surveyor. The Center for Transforming Healthcare is not a standards-based group. Our total focus is on transforming healthcare into a high reliability industry. Me personally, my background in nursing, but also in working with many sentinel events and root cause analyses over time, and looking at all the bad things that go wrong and understanding that when those bad things happen, no one got up that morning and said, whose day can I ruin, right? It's very unusual that somebody has the intent to harm someone, yet we do that a lot. Far more than we should. And so the high reliability work we're doing in the center really focuses on practical and tactical things that organizations can and should do to start to perform at higher levels of reliability, meaning every patient gets the exact correct care every time. And some of these organizations that we've been working with have been in a similar place to many of you in the audience. They're just starting to think about it. They're starting to talk about it. In fact, their CEO might not even be completely aware of what high reliability is. And so folks in your roles are the ones that really need to bring the concepts and the education to the leadership to help them understand that there are specific things that we can do to make sure that we are performing the safest care possible. And so we'll talk about that some today. My other piece of point of reference for this is my own background with my family and them receiving health care. And having been in a situation where just by virtue of being a nurse, I saved my father's life. And if anybody else in the family had been at the bedside, they wouldn't have had that same level of knowledge. And it's unfortunate because that shouldn't be the case, right? My father was in the ICU and he was receiving what we call TPN, just IV nutrition basically for non-clinical folks in the room. And he had about, 9 other IV pumps running because he was fairly ill. And I heard one of the pumps running very quickly, and I knew there was nothing he was getting that should have been running in at that speed. So I got up and I went over to look, and his TPN was running at 720 cc's an hour. Had I not been sitting there, it probably would have killed him in, I don't know, what do you think, 15, 20 minutes?
Absolutely.
And so I went and got the nurse, and she reset it to 72, which is the right rate. She hit the 0 before she hit start because the designer of the pump thought that was an ideal place to put a 0, where you could hit it when you hit start. So she didn't say anything to me. She didn't say thank you. She didn't say, oh my gosh, thank goodness you were sitting here. She didn't say I'll report this. She just fixed it and she walked out of the room. And so that was in 2006, and it's been my driving mission since then to help improve healthcare to a high reliability status so that you as family members or patients, because we're all patients, right, don't have to have a high level of knowledge to be safe. So, thank you.
Thank you, Coleen.
Thanks for sharing that. Just by way of hand, how many of you have had personal experiences with direct adverse events to your family members? So, yeah, a group of us have been collecting stories, and about a third to a half of healthcare providers say that they've had these personal experiences. And what strikes them is how, despite their journey, it's happening to them, as if because they're healthcare providers, the system will behave differently. If anything, sometimes it actually gets exacerbated. So thanks for sharing that, Coleen.
I'm Craig Clapper from HPI. When Paul talked about Cincinnati Children's, that was actually our group that does that. I'm not the sole person in the group. We have about 25 people. There's 3 high reliability communities. There's our healthcare community that's made up of mostly nurses and doctors. And then there's our aviation community. We work exclusively in healthcare, but they have aviation backgrounds, primarily naval aviation, like Bob Cady. Hi, Bob. And then there's the nuclear power community. And I worked in nuclear power, and then I did this work in transportation and then manufacturing. last 15 years, it's been like healthcare all the time. So in high reliability organizing, our thinking is where would we not use high reliability? There's absolutely no advantage to lowering reliability, and no consultant is ever engaged to make you unreliable. So we're interested in using HRO principles for safety, zero harm, appropriate care, everybody gets their best chance of a good clinical outcome, and then the broader patient experience is treating them with human dignity. In fact, now our group is part of the Press-Ganey family, and that's mostly because we wanted to work with Dr. Tom Lee and Dr. Jim Merlino. You probably know Jim from Cleveland Clinic. He was their chief experience officer, and then Tom Lee from Partners in Boston. Under the heading of Small World I knew his dad at General Electric, also Dr. Tom Lee, and he holds several patents on big electrical apparatus. So maybe Tom, as an eminent physician, is like underachiever in the family. So our big challenge in high reliability organizing is taking all of these descriptive theories and getting them into practice. And when Paul carved out our work this morning, I thought this is the perfect idea. Because right now, I think state-of-the-art in healthcare, high reliability organizing, is read Wyken Sutcliffe's book, Managing the Unexpected, and go around saying things like sensitivity to operations. I think our first step is to broaden our knowledge on descriptive theories. So we should know Wyken Sutcliffe, but we should know Westrom and Hudson. We should know Carleen Roberts' work, which preceded Wykes. We should talk about little-known authors like Bert Slagmolen. Nobody ever talks about Bert, maybe rightly so with the name. But then what about our friends at the Joint Commission? They were kind enough to put together a descriptive theory, how to do it in practice. What about Chong Chu from MIT? I left out Renee Amelberte. And I think Dr. Amelberte's value added is that he does the best at anchoring our reliability thinking around systems. See, the other people wrote mostly about people, and that's important. So I'll make this my last point as we get into the discussion, is when we're talking about high reliability, we should think about two types. This high reliability of the first type is mostly standardization and checklists and computers. And whenever we look like a factory in healthcare, it's okay to have that kind of reliability, because there are places where we look like a factory, like the pharmacy, like Central Supply. But then the other type of reliability, which is much more on your mind, is when we don't look like a factory, because healthcare is a complex system that is open and non-linear. See, these other HROs from like aviation and nuclear power, more linear and much more closed. And all the times I've flown as a passenger, my captain never left my plane to attend to another plane that was in distress. That never happened. So this one is more based on the word resilience, or you can say resilience engineering, and then the author you're looking there is Hallnagel. Eric Hallnagel, and you can study at his institute in Denmark if you like. And no fooling, it's in Middelfart, Denmark. Not pretentious like high fart or lowbrow and working class like lower fart. But he has an institute over there to study resiliency. And the key is, don't let your executive choose between this very reliable but brittle automation and this very resilient but error-prone people, is you want to merge those two together and say, that's our version of HRO, is that we don't make many mistakes to start things rolling, but the few that we do experience is we have that resiliency to think together as a team and prevent that from translating into an actual loss. So that's my story, and I'm sticking to it. And my answer to Paul's question was actually Kathleen Sutcliffe's answer. She says, if you want to get on an HRO journey, those are my words, not hers, you have to quit saying that you're a high reliability organization, because there are no HROs in practice. There are only HRO seeking organizations. people that know that they're somewhere between point A and point Z, and every year they need to figure out where are we and what are we going to be doing next year to take another step closer. So thank you, Paul. Thanks for having me up or over
Pleasure.
or down and across.
So, Craig, you've jogged a variety of receptors there. Jens Rasmussen, who's the father of all nuclear engineering safety, 30 years ago said, unless the engineers who are actually pushing the knobs in the control understand the principles that management uses, all theory is worthless. And his point, and he is a very difficult, very dense writer, but very, very thoughtful, was unless the providers, unless the nurses, physicians who are actually translating this into practice understand why you're doing this, except for marginal improvements, it's very difficult to demonstrate safety. So here's my question to the panel now. So checklists were mentioned this morning. I imagine you're all familiar with some work that's happened in Ontario and got a lot of attention last year, published by Urbach and his colleagues, in which Ontario decided to introduce a checklist into the public hospitals. In their wisdom to introduce checklists, there were several unique elements which are worthwhile highlighting because they position the question. The work was done centrally without any input of the hospitals. The hospitals were told that unless they have 100% compliance in their checklist, their budget will be cut by 10 to 15%. After 18 months in which they introduced checklists, or the 4-hour working rule in New South Wales for my Australian colleagues, there was no improvement. There was no reduction in harm. There was no change whatsoever to the previous 2 years prior to introducing these checklists. So here's my question to Coleen and to Craig. What is the role of engagement of providers as part of this high reliability organizational theory as the final arbiters of what gets to the patient? In your mind, where do you think the providers need to be as part of this transformation?
It's a kind of a multi-point answer to consider it. One of the things that we look at when we're looking at designing processes in healthcare and trying to understand the most efficient way to do things and still have it be the safest way is that you have to engage the providers in that redesign process. If you don't do that, you're not going to have their buy-in, and you're probably going to end up with yet another situation where you have workarounds, where people are trying to find a more efficient way to do the work that they didn't help design. So having the professional frontline staff, to use a Wyckoff term, deference to expertise, so you're deferring to the people who have to do the work and know best how to do it, is the most crucial point. Checklists can be very helpful, but when you combine checklists with mandating their use, you're not going to get what you want to get out of it. You're basically forcing people to do something that they might not find valuable, or that just becomes so rote, like I have to do this thing, that it's not done with any kind of reverence. To give you an example of that, the safe surgery or the wrong site surgery campaign that the Joint Commission started in partnership with the American Academy of Orthopedic Surgeons and 30 other professional organizations, looked at putting the universal protocol into place, didn't mandate a checklist, but said you need to do these things. And oh, by the way, one of the parts of this is you need to document when you've done a timeout. And so people started focusing on auditing and looking at documentation of the timeout, and the documentation doesn't tell you anything about how well it was done. And when we started to observe how people were doing it, we realized they're just going through the steps kind of mindlessly. And one of the most important pieces when you're doing a timeout is observing the site mark, right? Mm-hmm. And there are so many times when hospitals would allow the use of a regular ballpoint pen to mark a site instead of a durable marker that doesn't wash off completely, because they all wash off to some extent, that people weren't used to seeing a mark. So lack of a mark wasn't stopping anybody. Mm-hmm. But they were documenting the timeout, right? But it didn't prevent wrong site surgery. So it's this combination of understanding when a checklist is helpful to people, but still designing the process so it's attended to by professionals in a way that's reverent and done in a way that makes sense.
I love your focus on the word reverent because it really goes to the spirituality of improvement. You know, and the best Japanese improvement where Deming really perfected his ideas and learned a lot was about the spirituality of improvement. So how do you use the process to become a more present, a more engaged, a more reflective practitioner? Again, this goes back to the sharp enders, where value is created on the shop floor, the gemba, the gembitsu. All those terms are all about how does that reverence to the process, the presence and the process, right?
There's also a good parallel with the mindfulness. In fact, the Wyke and Sutcliffe book is all about mindfulness. So our thinking on physician engagement is authority gradient is the steepest between the provider and the team. And in resilience, it's all about thinking together as a team. I firmly believe what Coleen had shared with us is that checklists don't keep patients safe. Teams that think together using a checklist keep patients safe. Barcode scanning doesn't keep patients safe. Caregivers that use barcode scanning keep patients safe. So behind every really sharp-edged, forcing-like function that we have, there's a cultural aspect. And the weakness with HRO is that it can't be impressed upon you, mandated like our Ontario cousins, is that you have to choose to do it. So when you ask about physician engagement, sometimes the question is very trivial, like how can I get them to go to a 2-hour CME on patient safety? That's a different answer. How can I get them to practice those HRO behaviors, like using the checklist or thinking together or entertaining somebody who's speaking up? Sometimes it's even bigger. How can I lead them so that they engage in the work and improving the work with joy in their heart? And I think that's a key part about HRO is you have to do it with joy in your heart. I saw a thing on, I'll cite my source, Dr. Drew. And he was trying to counsel a couple, emphasis on trying. She wanted him to want to wash the dishes. He washed the dishes, but he didn't want to. But he thought that would be enough. And her total case was he didn't want to do it, even though he did. You can see, you can see where that goes. And I think that's where we are with physician engagement, is we're a little better at getting them to wash the dishes than to do it with joy in their heart. And I think there's an answer to finish where Paul framed the question, is that there's this idea called human factors integration. Coleen touched on that when she said, we don't like doing work that was designed by others, especially others that didn't understand the work. Well, I don't think there's a success path in us becoming human factors engineers and trying to design it in. But there is a success path in us trying to test it in or improve it in. So I think my answer to that might be through that robust process improvement, especially at the local level. Could we have local learning systems, kind of like in the Michael Leonard, Alan Frankel, two more anesthesiologists vein, where we identify defects and briefings and we work through shared governance to change our systems so that we have fewer defects and better practice? I think that would be a nice addition to trying to learn through problem reporting systems.
So how many of you find that your providers are joyful at work? Not all hands at once. It's not unique to the US, but it's particularly well documented in the US, is an increased unhappiness in the last 3 to 5 years of nurses, but particularly of physicians. We're talking 45% who say they're unhappy, they're angry, they want out, they want to retire early. These are remarkable and concerning data. The most recent RAND study sort of highlights that, but it's one of many. And so this idea of how to use HRO concepts as a way to drive towards joy or enjoyment, which is what this is about, because providers seek the medical profession, nurses seek the nursing profession as a path, as a journey, as a calling, and yet so many of them are unhappy. So I think it's a very powerful point, Craig, and I think it's totally lost on the traditional translation from the highfalutin principles of HRO. So a lot of organizations are focused on TQM, on Six Sigma, on Lean. they're very busy, so busy that when I worked in a recent organization, and we said, we're too busy to do lean principles. And so it's seen as one more thing. So I'll start with you, Craig. So you come to an organization that's been busy doing all these things, and they go, you want us to do one more thing, HRO? We're already busy with all these other names and nomenclatures and acronyms. How do they go down this path while not neglecting and negating all the commitment they've already done to improvement theory?
Yeah, that's a great question. I think there's some humor in it, especially if it's framed around lean, is that we're too busy to do one less thing.
Yes.
So I think what they're saying is that, well, we're too busy to engage in the learning work. So it's just kind of faster to do it the same bad way than to spend some time thinking about how to make it more simple. And if you want to read more about this, I'd start with a Hallnagel book. It's a little thin book, which is odd for Dr. Hallnagel. And it's called Safety 1 and Safety 2, the Past, Present, and Future of Safety Management. Kind of an unassuming title. And he points out that a lot of Safety 1 thinking, which is non-HRO-like, is safety is an add-on pack. Here's how you do patient care, and I'm going to add all this safety stuff onto it. Well, that just maximizes this effect that Coleen had put her finger right on and said that if you make it harder and harder, fewer and fewer people do it. Safety 2 is all about building the reliability into the work. So you actually do less, but it's done differently. And in Safety 2 thinking, it's mostly about resilience engineering, so it maps easily back to those 5 Wyke and Sutcliffe attributes.
What do you think, Coleen? How can they add one more arrow to their quiver without being overwhelmed by the work?
You know, that is a huge problem. We know that everybody feels under-resourced and maybe is under-resourced, but has so many things on their plate, and it just seems like throwing a dart at a board trying to figure out what thing to fix. But if you have a good set of process improvement tools, which is one of the things we really believe is required to work towards high reliability, you have some of the right tools that you need. And again, I'm going to go back to the fact that everybody in the organization should have some kind of experience with using performance improvement at some level. So without getting into the jargon of which system you use, if it's Lean or Six Sigma or some other thing, if you can demonstrate to folks or start to give them the idea that you will make your day easier if you can apply these tools in your everyday work, and they start to see examples of that, it perpetuates it. So just to give you an example, an organization I was working with is a smaller facility. They may average 90 patients on a daily basis, and on night shift, because that's their volume, they don't have anybody in central supply. Now, this organization is, working hard to meet the goals. So one of the things that they're particularly focused on is preventing venous thromboembolisms, or VTEs. And the goal is to have the whatever intervention you're going to have to prevent that in place within 24 hours. And they were meeting that. They were meeting it. But they felt that that wasn't good enough. And their roadblock, their problem, was that on night shift, the nurses had to call the nursing supervisor, wait for her to have time to go down into the basement, get the sequential compression device equipment, bring it back up to the floor, give it to the nurse, plug it in, put it on, do the whole 9 yards. But they were still meeting the 24 hours, and they said, we can do this better. What if we had the equipment in our supply room? Never been considered before. It's a lean concept. Get rid of the waste, get rid of the step that adds no value of having the nursing supervisor take time out of whatever else she's doing to go down to the basement to get the stuff. So now they had the equipment up on their unit, they were able to access it themselves, and they were getting these devices on the patients within an hour of coming out of surgery. Now, the science says 24 hours is the basic goal, but if I'm a patient, I think 23 hours without this device might put my health at a little bit of risk. And so to the patient, it's added value, and to the staff. And by the staff coming up with that idea themselves, because they'd started to learn about these tools, it made a huge difference in everybody's work and became safer for the patients.
Yeah. That's a good story. You know, I think it was Bradbury, the author. He said, "Advanced technology is indistinguishable from magic." But then, in parallel, HRO principles are indistinguishable from common sense. Because Coleen said, that's a lean principle, but everybody said, doesn't that just make common sense? That if you're going to use it, you'd have it like near to where you're using it? And there, I think, is the classic, we confuse one of the tactics with the overall whole. But whenever you're talking about the whole and converting into tactics, it seems to stand alone as an intervention or a good thing to do. But I think the HRO lesson is that don't think of it just as tactics, like do this, do this. Have some framework, like a blueprint, and then build to that. Because you'd be much better off, let's say, with Lean, if you had several aspects of it, like the local learning system, the daily management system. I think we have a question in the making over here, if we get the mic running. And then the leadership aspects you could run as a standard work for leader or a daily management system, whichever you prefer.
And and there's mics in the back, so if you, whenever the urge comes to you, pick up your hand, and we're delighted to interrupt our flow for a great question. It's all about that. Yes, please just introduce yourself.
Maurice Janssen, I'm a clinical physicist from the Netherlands, so happy to visit this conference. I really liked your question about how do I get people to do something although they're already saying they're too damn busy, which we all happily are. And I thought about one of the great presentations we got 2 days ago, so I just looked it up digitally, sorry, that's easier for me now. It's on the power of intention, evaluating of impact of self-efficacy on patient safety prevention. And that's what from Suzanne Davis 2 days ago. And there was one great question in there. If you have to get people to do something, you have to ask them a question. So don't give them a framework, don't tell them what to do. She said, how confident are you in your ability to prevent patients' falls? As a good example, just ask them. Ask them, what are you capable of doing something, and if not, what do you need? So I'm not going to give them a framework, I'm going to ask them what they need. I think that's crucial, and then they'll do anything, in my opinion.
That's a great point. So essentially, by asking them, you're respecting them, aren't you? You're bringing them into the process. So Coleen talked about, these fundamental skills, and we've been studying what I believe is the most important skill in healthcare. I want to ask you how many of you are actually doing this and teaching this, and that is process mapping. Process mapping as a way of thinking is so fundamental. So in my mind, HRO begins with understanding the process. That's not part of Sutcliffe and Wyke because they're not engineers, they're psychologists. But the engineering aspect of the cognitive workload is all about understanding the process. Very simple to do, very simple to teach, literally really simple to teach. And once you give them those lenses, then the waste work, what Berwick calls the muda, suddenly gets exposed. Because when you see what your process is and you see where all the attention is, that discrepancy immediately highlights where the opportunities for improvement are. That's HRO in my mind. You can't get to reliability unless you understand your processes. And it's silly to even think about HRO if you don't understand your fundamental, where your people are, where they're spending their time, why they're not at the bedside. Well, they're not at the bedside because they're chasing down supplies. You don't need HRO principles for that. You need processes, understanding for that. So the next question I want to focus the panel on is, so management is struck by a tension between safety and productivity, Coleen, right? A constant shifting perspective where everything is being measured and monitored, where there's more and more penalties around either readmissions or around infections or around never events. How does all that align with this gospel for improvement? So how do they deal with the tension of HRO principles while trying to deal with productivity and operational drivers?
So what you're talking about, I would say, is safety and versus production. And you're asking how staff can respond to that, is what I'd say. And one of the things that you as leaders in your own organizations can think about and do is tell your staff, come tell me when you're feeling production and you feel like it wasn't okay for you to say stop. We see this a lot, for instance, in the OR, where they're hurrying to catch up the schedule. And when you hurry, when you rush something, when you have time pressure, bad things happen, right? So the frontline staff, and you've got leaders, I'm sure, in your organization in the front line as well as at the high levels, are the people who recognize this. And maybe they feel like they should say stop, but they don't, because they don't feel empowered. And so what you can do as leaders in your own organization is ask them to come talk to you when that happens, so that you can start to understand, as Craig said earlier, about the power gradient, because frequently it's a physician team issue. And if you're going between two ORs and trying to take care of two patients and you want your team to just move, and you don't have the right equipment in the room and now you have to rush to do that, and nobody says stop, I think we're getting into an unsafe zone, then who's going to suffer here? The patient, right? So I think that's one of the things that we as leaders should do, is to encourage everybody to stop and speak up and not to condone production over safety.
So Craig, Amy Edmondson talks about psychological safety as the single most important element in driving productivity. So in an organization, hierarchical and an ancient culture in healthcare where there's a lot of inbred secrecy and a lot of fear, how do you get to that openness? How do you get people to speak up on the one hand while still holding them accountable when they're disruptive or rule breaking?
Yeah. Yeah, that's a good question. Is that I think her easiest read is the teaming. She wrote the book Teaming.
Yeah.
And think of two attributes. Is you want to have this mutual respect, and then you want to have collaboration mechanisms or tools or processes, ways for us to interact. Most of us were trying to solve that problem on just one side or the other, and you need both, because that culture will exist where those two attributes overlap. Is there, everybody that works in culture change today uses behavior models. So to make it more simple than it appears on paper, is you need to define behaviors that are consistent with that mutual respect, and then work them into practice habits. And you have two basic thrusts, which I'll call reinforcers and enforcers. You want the reinforcers to be very frequent, like daily, but then you want the enforcers to be there. Hopefully we'll never need it, but we will use them if we need to. And they're an interesting case, is a Swedish medical center in Seattle. Like many now, have a subset of their peer review dedicated to citizenship, the behavioral aspect. But they pointed out in one meeting that there's 12 of them on that subcommittee, and they predominantly talk about 12 physicians on the medical staff. So they have a committee of 12 that talks about 12 other individuals. So I think at that point, you're better off playing man-on-man defense. And there, I think the Jerry Hickson model is instructive as well, as a way to kind of bridge those two, reinforcer and enforcer.
So, and of course, since you mentioned Jerry, so are you all familiar with the Hickson model from Vanderbilt? So at the heart of Jerry's model is the ability to bring together in a common information platform patient outcomes, disruptive behaviors, complaints, and productivity, if you will. It's a way to have better management principles. That is to say, transparency of the data in the hands of decision makers creates accountability. It forces transparency, it forces a different level of awareness of what's going on. Absolutely, very powerful. When we talk about accountability, and again, I think this might even be an HPI slide that I've seen, the 3 different levels of accountability that HPI has spoken to. I'm always struck by the fact that when you look at medication adverse event studies, less than 10% of events are reported by physicians, or I should say somewhere between 5 to 10%, which I find always amazing still, that 90% of adverse drug events are not reported by physicians. Is that your experience as well? Does that strike you as strange? So all that wisdom, right, all this information is happening, but the providers don't report. So why do you think they're not reporting those adverse events? What do you think, Craig?
Yeah, I think it's a twofold solution. A lot of people talk to me about number one is they don't want to create trouble for themselves or a colleague. I think that's actually number two. I think number one is they don't really see the value added, because we put data into those systems, and are we really using it to improve care? So there, I think if we use these learning systems, like electronic problem reporting, make it easier, get it on your devices. I mean, we call it a phone, but it's really a computer that we carry with us, is that then they start to see some value added, and they can now use that to report defects and stimulate action. I think that's the real reason.
You know, I like that, and when I think about value, I think about values and the tension between value and values. And my framework of HROs is how do these principles reinforce the values of the organization, which really goes back to why providers should pay attention. So how do we use those HRO principles, Coleen, to reinforce the values, the organizational principles that keep these people working together?
That's a great point, and I think it also speaks to the fact that when you have everybody so busy and feeling like they can't add one more thing, if you have as the overriding core value of the organization that safety is your #1 priority, in fact, your only core value, it becomes easier to have everything else follow. Because you've stated it as an organization, your board hopefully has enforced it. Even if they don't enforce it right away, you'll get them there. Not enforce it, but endorse it, I'm sorry. And then it starts to trickle down to your frontline staff. And so you may be making over the organization in some ways because your values or the behaviors that you're seeing people do every day may or may not be about safety first. It may be about what you're not saying, but what you're enforcing in terms of behaviors, the production pressure or the money or those kinds of things. There aren't many organizations in this country, many hospitals in this country, that have said safety is our #1 core value. But the ones that are doing it, the ones that have done it, have been on a high reliability journey for a while, and they're making evident progress. They're seeing 0 as the most common number that's reported for many of the adverse events we try to prevent, like CLABSIs and CAUTIs and those types of things, and surgical site infections and so forth. It's a paradigm shift. It's actually flipping the paradigm upside down, because in healthcare, our focus has traditionally been on finance, right? The board, they're only concerned about the money, the numbers, and not about safety. And if you flip that upside down and you say safety is our sole priority, it's our core value, it's what we focus on, then all the rest of the stuff follows that. The money follows, the efficiency follows. Because if you get the safety part right, the rest of that will happen too. But it's a hard thing for organizations to say that. But those that have seen significant progress in that arena.
Yeah, that's the value proposition, is that safety culture doesn't exist well without its partner, high reliability organizing. But once you have the high reliability as an emergent property of the system, you can use it for every objective that you have: quality, satisfaction, employee satisfaction, physician satisfaction, personal safety. So it gives you a common framework or chassis on which to build your success. And that's the value proposition. Safety does lousy in a tie for first place. And it does very poorly in second place. So it doesn't show up in those.
You know, Paul O'Neill, the previous CEO of Alcoa and then the Treasury Secretary, has this lovely one-liner. He's got several great one-liners. One of them is that if you're in healthcare, your value can't be safety. It needs to be your prerequisite for even being in healthcare. You don't deserve to be in healthcare unless safety drives everything you do.
So it has to be more than a priority.
Absolutely.
The precondition.
It can't be a PR slogan. It has to be about the DNA of the organization. It's a very powerful way of framing it. And I encourage you to look at a Harvard Business Review case written up about Alcoa and how he took a company that was at the bottom of aluminum manufacturers, one of the most dangerous companies, to be not only the best in aluminum, but be the safest company in the world by lost worker days. That's how it's measured. And what you see in this case is, as opposed to traditional management, he focused on one thing, which is reducing the number of lost worker days, and that's how their productivity and that's how their financial benefits improved. And that's what he held his executives accountable for. How many harmed workers are there? Not how many things are you making. Because if your workers aren't being harmed, you're ultimately going to be making a lot of money. And that really flipped the equation around, as opposed to how many widgets are we making, how many workers are we harming? And think about that as part of the staff safety. And as Craig alluded to, we talk about patient safety, we don't talk about worker safety. And one of the things that struck me, I've done a lot of work in transportation safety around changing speed limits, et cetera. And I've seen at least 2 or 3 providers either die or nearly die driving home post-call. In some other countries, like in Scandinavia, notwithstanding the recent comment of Hillary Clinton in a debate that we're not Denmark, in Scandinavia, post-call, you get a voucher that takes you home with a taxi and makes sure that you get back safely home. So is the hospital responsible for the wellness of a provider after they've done a 12 or 16-hour shift? Or is it up to them to do whatever they can to get home in one piece? It's a very interesting question. So does the responsibility of the organization stop when the provider leaves the building? Or if because of the work imposed upon them and the fatigue, should that also translate to getting them home alive to their family and of course getting back the next day? And so this question of staff safety, so how do high reliability principles relate to staff safety? And how can we get them to engage if they feel that the organization cares about productivity but not about their wellness?
Yeah, I'll just make a quick point. Wasn't that an interesting point from Paul, is that whether it's patient or provider, care kind of ends at the boundary of the hospital. And I think both of those have to change.
I was thinking the exact same thing.
Yeah. And of course, a lot of the work on readmission management and the penalties have sort of highlighted this fallacy that care somehow stops and the continuum stops at the door of the facility, when in fact we know that patients care very little if processes fail before you leave the hospital or a moment after you leave the hospital. It's the reliability of the process above and beyond the physical geographical distinction.
But risk managers have extended the boundary.
Yeah.
I'm not sure the number, but how many feet from the front door and then it's so many hours after discharge? We've extended it that far.
Well, you know, I think Geisinger got a lot of attention a few years ago when they said that they'll give you a 90-day warranty after surgery. And this is in the era where some of the best manufacturers in the world are giving you 10-year warranty on their devices, these complex devices. And Geisinger, was, for the first time, had really explicitly, as an organization, said, 90 days after surgery, if you have a complication, we'll take care of it for free. Fascinating tension about, is healthcare offering that type of warranty, you know, and is that part of a reliability model when the relationship is an ongoing relationship? But it really also connects to this issue of itinerancy. So, you know, we spend a lot of money and time on training. Healthcare is famous for having a very high turnover, particularly amongst nurses. So how do you get to HRO principles in a sustained manner when your staff turn over on a regular basis? So how do you decide where to invest and where is the ROI on investment if you know that your nurses are turning over every 18 months or so? Coleen?
Well, I think that's a great point, especially for our military colleagues in the room, because you have designed workforce turnover. I mean, your entire leadership can turn over every 2 years. Half or more of your frontline staff is going to do the same thing as they're deployed and they move around. So how you combat that is you have to bake in the training. It can't be one person's job. It can't just be the quality people or the HR people who are responsible for the training piece, because you've got a lot of people to train. If you have, if you're an academic center, you've got a whole bunch of residents that you have to train. And how they're trained in one specialty may not be the same in how they're trained when they go to the next specialty. And so having it baked into the DNA of the organization, the training piece, and having it be everybody's responsibility and not one person's responsibility is one of the primary ways that you start to get that done. But there's another aspect of it which I think we're just starting to recognize in healthcare, which is, why aren't we training high reliability and safety in school? Why aren't we doing this in medical school and nursing school and pharmacy school? And oh, by the way, why aren't we teaching all those disciplines to talk to each other? So where I live in Chicago, we have University of Illinois, which has all of those schools on one campus. And it's an ideal opportunity to start to teach those different disciplines to communicate to each other. When I was a new nurse, I had the conundrum of not being taught as a nurse how to communicate with a physician. Nurses have, a lot of times, we go on gut feel, right? Something feels wrong about the way this kid's acting today. How do you translate it feels wrong into here are the facts, physician, what do we do next? So those training moments, they start in school and they continue. And these are things that you can seize the moment as you've got people meeting in some multidisciplinary venue and bring up these factors. So not only is it the DNA of the organization to make sure that training occurs, but you're also using training moments to do on-the-spot training so it doesn't feel so onerous to people, and it's just part of your daily work.
So years ago, a group of us developed team steps, and I imagine all of you are familiar with team steps. What isn't really apparent in some iterations of that is at the heart of team steps was the clinical microsystem, the smallest unit that's measurable. So holding the team accountable as a team and reinforcing those values throughout every moment. So it might be through huddles, it might be through briefings or debriefings. And before we started, we were talking a bit about surgical teams. I've spent 20 years in that space. And it's amazing how we train rigorously individual providers. We spend almost no time actually learning from each other. So we occupy the same piece of real estate, but we don't actually truly engage as a team. And there's some very core elements of what teamness is. It is not necessarily working in the same real estate alone. There's a whole series of principles that requires one to work together, shared accountability, in fact, the core principles of HRO. But part of the challenge is, and Craig, I want you to reflect on this. Atul Gawande, in his recent book, talks about the fact that a lot of physicians feel adversarial to the comment of systems thinking because it goes against my sense of autonomy, my sense of the fact that as long as I do the best I can, that should be pretty good. And so there's this tension between this mantra and rhetoric about systems theory. On the other hand, there's my bond and my pact, and I'm doing the best I can. And so the question really is, a lot of HRO theory has come from industries, as you alluded to earlier, that deal with linear processes, with very clear heuristics and very clear elements, and yet healthcare pushback might be that it's different in healthcare because the patients are different, they bring a complexity, we don't know sometimes what they bring to the table. How do we deal with this linear model and its very clean and neat principles versus the messiness of healthcare and the utter chaos?
Utter chaos,
Yes.
utter chaos, yeah. Historically, safety and quality, for that matter, has been viewed as a competency of the individual. They were either poorly trained or well-trained. And that might have been true at some point, I don't know. But I know today that the systems are so complex that nobody gets to see anything from beginning to end. So that kind of reliability is an emergent property of the system. It arises out of interactions of pieces of the system. I think our best appeal, particularly to the physicians, is to talk about the two different kinds of reliability. Is that when it does look a little more linear, we want it to be more standardized and more like the factory. And that tends to be brittle, and that's a weakness there. But then when we talk about medical decision-making and how they're doing their procedures, I think that's where their expertise should dominate. So whenever we say we want to standardize, I think their reaction is, well, they're going to tell me how to do my procedure. No, that's where your expertise is going to govern. But when we talk about standardization, I mean, that's like getting the patient to you for the procedure and what's going to happen post-op. And there, I think the physicians are very open to saying, I want that to work. I want that to work for us. So it's really more a matter of how.
And I wonder, I find that many providers have a really hard time with the word standardization. So I've co-opted the word harmonization. And what I mean by that is by engaging the providers in translating these tools into their local practice they feel more ownership. And a lot of the research around CLABSI and around surgical checklists and around falls management seems to suggest that when you invite providers to adapt these standardized tools in a way that conforms and respects their own needs, values, and organizational legacy, there's a much higher chance that they'll be compliant because they own it, as opposed to borrowing something from somebody else and saying, you must do that. You know, Coleen, do you want to reflect a little bit on that?
You know, I think that's right. There is a lot to be said for having a standard tool and having the ability to adapt it to what your organization is doing. I think we still have to guard against, you like the word harmonization, I like the word the term driving out variation. So if you've got 7 cardiac surgeons at a really large academic medical center, and they each have their own preferred mix of solution that they use when the patient's on bypass, it's called cardioplegia solution. Pharmacy now has to make 7 different solutions. But be proficient at crafting 7 different solutions. This is an actual healthcare example. And eventually, they're going to make a mistake. And that cardioplegia solution is probably going to irreparably damage the patient's heart if it's mixed incorrectly. And the patient's not going to be on the transplant list. So I think there has to be a balance between having the buy-in and the ability to customize a tool to your particular setting, because you are different than the hospital up the street. Your challenges are not their challenges. So that's important
How
to
about
pay
within the
attention
same
to.
hospital? Have you found variation between departments?
Oh, absolutely. And so understanding when variation is bad is crucial. If you know that the science says this is the right way to do these series of steps, for instance, central line insertion, there's not a lot of guesswork around that. We know, follow these steps and you will not have central line infections, right? But if you want to customize that, that's a bad idea because we know what the steps are. So the healthcare being messy part of this, though, is we don't have a lot of things in healthcare that we can say that about. But if you know that there's science behind doing things a certain way, driving out that variation, which is the magic of Six Sigma, is phenomenal. And it totally improves your safety and your outcomes.
Yeah, because it's not the same as repeatability that we do it the same way. It means that we hit that leading practice every time. So wherever we have the evidence, we need to be using that evidence.
But in order to have the evidence, we have to be measuring, right? So measurement at the heart of, go ahead, Jim.
Right. So to be asked a question, and I'd encourage some other questions as well, but so you talked about product warranty, right? And we talked about retail environment and healthcare through consumerism, transparency, and disclosure has to move to retail model. That's the way reimbursement's going as well. So having just come back from Japan and reminding me of the early 80s when I was proud of my Chevy and the products that were put out by Detroit and other manufacturers were not very good quality. So where did consumers move to? They moved to products that worked. And I'd argue that, millennial generation especially, that has everything on their phone, they don't care about the system problems. They don't care about the issues that impact the deliverable that we're trying to put out, which is a good product. They just want it to work. So how do we move from where we are in a complex nonlinear system and engage employees that are disengaged to contribute to really doing what's most important, and that's the best clinical and quality outcome you can?
You guys want to take a stab, Craig?
I'd like Coleen to go first.
Well, that's an excellent point. So one of the things that we kind of screwed up a bit in healthcare, when I first started in nursing, it was a very punitive culture. You weren't going to report a single thing because you were going to get fired or written up or something bad. And then we wanted to kind of erase that effect, and we swung the pendulum way too far the other way. We went to this blame-free culture. Well, now it doesn't matter what you do as long as you report it, all is good. Well, that's wrong too, because you have to have accountability. So to your point about how do you engage these people who don't care about the system, you build accountability into it. And if you do a good job at putting a just culture algorithm into place, there's a couple good ones out there. James Reason, phenomenal PhD in the UK, and then also David Marks here at home. They both have one that you can implement. if you implement it in a transparent fashion and uniformly among both your physician staff, employed and voluntary, and your employed staff, your frontline folks, even your administration staff, you start to make it obvious that it doesn't matter if you're engaged or not, this is the expectation, and we're going to be clear about that. So this one organization we were working with, they were trying to drive in safety culture, and they were trying to make sure that their staff could communicate to each other in a very busy labor and delivery unit, where teams have to click phenomenally well. And there was one obstetrician who was very intimidating and had comments that he would throw off to nurses, and they wouldn't even want to talk to him. And when they were concerned about one of his patients, they couldn't even bring it up to him because he would be dismissive of them. So the CEO was fully backing the safety culture work this organization was doing, as was the chief medical officer. And they said to the nurses, they went to a staff meeting, and they said, you tell us the next time this is happening, and we will be there. I don't care what time it is. Here's my personal cell phone number. You call me. So the next time it happened, it was 3 in the morning. They called him, the CEO. The CEO and the CMO put their clothes on, drove into the hospital, walked in, pulled this physician aside, and they said, this is not okay to behave this way. This is not appropriate behavior. This is not acceptable in our organization. Here are the parameters by which you will behave. Had this conversation, expected that the physician would improve, and the nurses were like, wow, they came in. That's great. That's awesome. 2 weeks later, happened again. They called the CEO again. The CEO came back, and they said, we were very clear on the expectations. And as they put it, this physician self-selected out of the organization.
Wow.
And if you want a wildfire safety culture change, you can imagine that story going from that nursing unit around that hospital in a matter of minutes. The CEO came in, and that surgeon or that physician is no longer here.
For that second intervention, did they put their clothes on?
They did. Yeah.
Okay.
So I'm going to,
For the record.
for the sake of discussion here, I'm going to argue that physicians are not the problem. I'm going to argue the physician is the fact, the way we've socialized providers to misbehave over time, and that physicians, when you actually engage them in the proper way, they will not become disruptive. So the problem is not the physicians, the problem is the way we've socialized them to allow to behave this way. What do you think?
Oh, I don't mean to pick on physicians. That happened to be an actual
No,
real-life example, because nurses, you know, right?
Yes,
We eat our young.
yes.
Yeah, but we don't have a
that's-
disruptive nursing policy or a disruptive therapist
There
policy.
should be a disruptive behavior policy.
I think it's
that's
because
broadly applied, yeah.
our more mainstream accountability systems are functional in dealing with those. That's why they don't exist. I think the problem is we're trying to instill that same accountability through the independent credential provider model.
Yeah, very much so.
Which
very
is
much so.
tough.
Questions or comments? There's a few
Yeah.
people. Yes.
Finances. You know, many times we come across a situation where it's very obvious, everybody knows the one
Yes.
physician who is the issue, but he's bringing in millions of dollars a year. And, you know, it's not a culture of safety, and it is allowed and people don't want to approach them. And so that's what we're talking about. That's one of the issues of what may prevent them. And so I would admire a CEO who would come down at 3 in the morning and take steps to prevent this type of behavior and send a message that we really do support a culture of safety.
Yeah.
So.
Every organization should have a leader toolbox for HRO, and every toolbox should have one of those just culture algorithms. So Coleen had talked about the Reason tool and the Marks tool. I'd also add the Hudson tool to that lineup. And there's no downside to having two tools so you can get a second opinion.
Absolutely, and there's this wonderful statement that comes from theoretical physics, which is applied to healthcare, which is all models are useful sometimes. They're just models. The Swiss cheese model is not about Swiss cheese. It could be brie cheese. It's a model, for God's sake, and that means realize that multiple models creates rigor, diversity.
Yeah.
Sometimes I'm struck by people who join the movement of safety and get so locked into these these draconian ways. And I think that is a recipe for pushback, because it requires the nuances around the model. So multiple models means you have more tools. It means more ways to deal with this complexity, not less models.
Yeah, the Swiss cheese effect is it's a complex linear model. And the Rasmussen model, the dynamic safety model, is complex nonlinear.
That's Brie.
Or at least Helvardi.
Or Hardy, yes.
There's an OB safety article called Getting to Havarti. But my point is, if you want to manage both kinds of reliability, is that you'll take a situation and you'll look at it from the Swiss cheese perspective, but you'll look at it from the Rasmussen dynamic perspective
Absolutely.
as well.
Please.
So Coleen,
And
you
just
meant.
introduce yourself.
Oh,
please.
I'm sorry. I'm Donna Patey, and I come
Yeah.
from Kaiser Permanente in Northern California.
Yeah.
And we are really trying really, really hard to be a high reliability organization. I wanted to ask about your opinion of using simulation to improve communication across disciplines. We're using it more and more. We use it a lot in the operating room. We use it to test checklists. We use it in labor and delivery for shoulder dystocia, for maternal hemorrhage. But I think the biggest usefulness for it is in flattening communication between physicians and nurses. It's an opportunity to practice SBAR, and when we have physicians playing nurses, they learn volumes about how they communicate.
I love that you're having physicians play nurses, and maybe vice versa too. Simulation has been in wide use in high reliability industries other than healthcare for a long time. Nuclear power heavily uses it when they have their evaluation visits, equivalent to accreditation surveys. The evaluators pick a simulator scenario, and no one in the organization other than the person that programs the simulator knows what it's going to be. They can pick whatever they want. Just to evaluate how people perform under pressure, I wish we had something similar we could do in all healthcare organizations, but not everybody has the money for the technology right now. But you probably have a university nearby that has simulators that you could buy time on. I think that simulators are a phenomenal way to improve communication and to test people's reactions in high-risk situations that you're probably rarely going to run up against.
Absolutely. I would just add there's a pushback around simulation because there's a disconnect between the education and operational parts of the organizations. And so simulation works well when it's highly connected to operational drivers. I say that because a lot of money has been invested in simulation, and anesthesia was the first really in healthcare to go down this pathway. We've learned a lot by where not to invest in simulation when it's disconnected from what drives value. So again, the point is it's not about an educational principle, it's an operational principle to use simulation. It should not be under education. That's a big difference, because it means that it's driven by what really matters. And that means the people that use it value it, including cross-disciplinary role-playing. I mean, I did this in the military 35 years ago almost. This concept of being in the shoes of somebody else dramatically opens up your eyes to the insecurities, to their needs, and to the issues around that. I'm curious, how many of you use patient stories on a regular basis in meetings or conferences? So, and this question is to the panel. We just published a book this year in which we collected 24 stories, and we used the stories to drive reliability. And so here's a question to the panel. How would you recommend organizations use both big patient stories that are out there? It could be Helen Haskell's unfortunate outcome of her child, or of course the Hopkins unfortunate story.
Josie King.
Josie King, thank you for that. But how would you best use organizational stories to drive the principles of reliability? Craig?
Oh, don't leave us hanging. What's the name of the book?
There you go. Here it is.
probably
Case
on-
Studies in Patient Safety.
How's that? So we can be on Amazon while we're talking. Yeah, you know, storytelling is the most effective leader behavior because of frequency. It's done every day in multiple opportunities. In fact, when you round, you're actually taking your storytelling onto a situation. And if you're into lean K-card systems, The word that gives us the K, I think it's Kanishnaba,
Yeah.
means storyteller. See, it's set up as a check system, but you're out there telling a little story on why we're doing this and why it's so important. So I would recommend that you have leaders who are proficient in storytelling. You don't push them a standard story like every week for them to deliver in a half-assed way. That's that real term, assed, A-D-Z, half-assed. Is that you teach them to relay the story in 3 parts. I'd like to tell you a story about the importance of speaking up for the patient. Then you tell your story with characters and plot, and then you come back to that's why we speak up every time, and that's why it's important that everybody every time does it.
So really what you're speaking to also is how to not just tell the story, but ensure that the story has some clear translatable messages.
That's
I think
right.
we
Translate the big picture into that.
And a lot of
little
times
picture.
we've used stories thinking that the story by itself should be enough to change behavior, and yet realizing that's not enough. It has to be coupled to clear competency drivers around what this means to your action tomorrow.
Exactly.
Versus a few tiers, how could this have happened, but then moving on. Yes?
I was asked to share our story of how we use stories, and we begin every meeting with a story, and we have a monthly meeting, a quality council, as well as
Where do you work?
Kootenai Health
Oh,
in Coeur d'Alene, Idaho.
In Idaho.
And we've learned all about stories from HPI. But one of the things that we really deal as it relates to a difficulty in telling our story is how much information and where does it become, as you had alluded to, really, based in theory or based in some kind of literature review. And it really takes away the sensitivity of that story. And then one of the other challenges that I've given to our hospital is we saw a lot of people raise their hands when we were telling our own stories. I even have a story around my mother, around your father. Why don't we start sharing our own stories within the organization of how staff families have been affected? And I think that might drive home just how personal this issue is. Start there. And they haven't picked up on that, but I think that's a place where we can share our personal stories within the organization.
Great.
Yeah, you have to think in terms of signs and symptoms. Like on standardization, preference cards are a sign of low reliability. The same is true in storytelling. Storytelling is like wound debridement. Is that debridement? I should just remember I always say it wrong. It's necessary and it's uncomfortable. So if your stories don't make your risk manager uncomfortable, they're not working. And if they're not scaring your general counsel outright, they're not working. Those are good signs of HRO mentality.
Well, the most powerful thing about stories is that, again, they contain your values. And healthcare providers are storytellers par excellence. The best way to engage physicians is through stories, because that's their language. You might think they're all about numbers, but their healthcare in its origins is all about stories. So it's a forcing vehicle to tell our values through our stories.
To drive that home, Paul, is that you tell a nice story to a physician, they say, I'm sorry I didn't follow it. You go, oh, my mistake. I forgot to say this patient is a 56-year-old male with 4 comorbidities. And oh, I get it now. Because they put everything in the context of a story.
Absolutely.
It's just a brilliant observation.
Absolutely.
But then this takes us back to the culture of fear, where, again, we can't just have stage stories that all sound great. I mean, we're going to have to share ultimately good, bad, and indifferent things that really impact and move patient quality in the right
So thanks
direction.
for that. So we tend to focus a lot on the negativity. I imagine you're all familiar with David Cooperrider's appreciative inquiry, and his emphasis in relevance healthcare is that if you have a 1% adverse event, that means 99% of the time there's good things going on. Those are great stories as well. And you can learn just as much from what goes well as it relates to the culture as much as you can learn about what goes poorly. But the difference is people are much less defensive, much more willing to share and invite. So using the positivity of the stories, not just the bad ones, but the good ones, I think is usually powerful in reinforcing the things that Coleen and Craig have mentioned. Yes? And just say your name also, please, Abigail. Thanks.
My name is Abigail Smith. And I just said, that I'm not sure whether it's good or bad to say that I have 25 years in this field. That's where the gray hair comes from. And what is really scaring me and upsetting me about this session is that the story about the SCDs is a story that I have known about for about 20 of those 25 years. I mean, I think we had that same exact example. And putting that together with the idea that you can't tell people what to do, but they have to learn it and devise it from the ground up, it sounds like we can't learn from experience. That really bothers me. I read the AHRQ and M&Ms and the web information and information from other people. Why can't we take what other people have told us and figure out how to apply it instead of starting at the base? And I think that's what the next lecture series should be on.
Good question.
That's an excellent point. I mean,
Coleen.
we know that hand hygiene prevents infection, right? When did we learn that? Dr. Semmelweis
150
figured that
odd
out
years ago.
150 years ago. And we still do it maybe 50% of the time on average. So that's an excellent point. We know we should wash our hands, and we don't.
Thanks.
I saw a couple hands up over here, too.
Yep.
Were they washed?
Hi, I'm Carrie Panasco. I'm from the Midwest Alliance for Patient Safety out of Illinois. And I think one of the things that when you go to this conference, you're finding that little light bulbs should be going off about reaching out to other hospitals, because everyone has learned something, and unless the silos are broken down and we actually get to share all of this outside of our own organization, there won't be a movement for change in how we operate.
Great.
So that, I think, is something to take back
Yes.
from a panel discussion.
Coleen had mentioned our nuclear power friends, and through an industry organization, IMPO, Institute of Nuclear Power Operations, they do most of their learning in learning from events of others. So I believe they're the superior model.
Absolutely, and since you mentioned IMPO, so there's a wonderful book called Hanging by Each Other. Which is
Hostages of each
Hostages
other.
by Each Other, thank you, which was written after 3 Mile Island, in which the nuclear power business realized that if they didn't collaborate and learn from each other, they would all hang by each other. And ultimately, that mutuality is where it's about. So every time there's a bad event in healthcare, we all get a black eye. It's not just one hospital. So we're all highly connected that way. And so learning from each other and solutions, including from the Netherlands or Australia, where there's a lot of really good work going on, is an example of things that we can take away. Yes?
Right, and I think with the storytelling like we're talking about, in our organization, we've done a lot of storytelling and learning safety behaviors over the last year, and that's really important. But again, I think you have to add those other concepts we talked about, is you just can't tell stories all the time. You have to have accountability, and you have to be able to have that decrease that unvariation that's going on and make things consistent. So it's like connecting those other hats of risk and patient safety and quality all together so that you work together to have outcomes that are very beneficial. And that's hard to do, and it's also hard for staff to really own it. They have to own it and like you said, have that engagement. So I think that's really kind of the challenge, is to bring in that just culture appropriately so that you can move forward. So I think that's kind of the name of the game. We're taking our safety coaches in the next year, and it's kind of grow with purpose is our theme. So how do we identify something that we feel is important, and we use those safety behaviors to make sure it sustains, it implements, it's there, so that we can move to other things that are critically important as well.
Good. And where do you work?
Spectrum Health Gerber Memorial in Michigan.
So Craig, thank you for that. I will posit that it takes at least 10 years to get towards a medium impact of reliability. Would you agree?
Yes.
And to get to high reliability, it takes a generation. Would you agree?
Yes.
I'm not convinced. It might be longer.
Thank you. The point, of course, is that this is a journey that takes decades.
Yeah.
And this is not in any way to undermine your work. It's to have more realistic expectations about how hard it is to get people to change their behavior. I teach risk management for an entire year, and the first several weeks is choose one behavior that's bothered you all your life, that you or your loved ones have mentioned, and see if you can change it. And see how hard it is to get your own self, when you have full control, to change that behavior. Now you're asking other people who actually are pretty comfortable with how they're doing what they're doing. So this is really hard, this change work. And so it does take many, many years. And it's a slow and gradual and continuous process. You don't solve safety or reliability. You emerge and you work with it on a daily basis because it continues to threaten your viability. We have a few final moments. So I want to just, any more questions before I ask for the panel for some final comments? Anybody? Okay, so Craig, why don't you go first, and Coleen will go last. Some
Yeah,
final
I'll be
thoughts
very
and
brief. To summarize, I think what we learned today is that the solution shouldn't be confused with the overall concept. So like storytelling might be number one, but we need that just culture algorithm. So I would focus everybody on what is our version of high reliability leadership and teach a broader toolbox.
Coleen?
And I would say, too, that you still need to think about what is our overarching goal as an organization. And if it's not safety, then having a conversation with your board the next time they set for you an incremental improvement, such as we're going to decrease our surgical site infections by 5% this year, that you challenge them with. So you're saying it's okay for us to kill 15 people this year with surgical site infections, because that's what that means. So bringing it always back to safety as the overarching theme, I think, is the glue that's going to kind of hold this together and let you move forward towards high reliability.
So before we wrap up here, first of all, here are the emails of Craig, Coleen, and myself. I encourage you to reach out to us around these issues. There's some cards here about the book if you're interested. On the website, there'll be more materials, including a summary of this workshop. So we hope you'll continue to engage with that. Join me, please, in thanking our great panelists, Craig and Coleen. And of course, CRG for sponsoring this event. And I hope you have a great rest of the meeting. Thank you so much.